Hello guys, welcome to my YouTube channel Dr. Shahnawaz, and in this video you will see that how we can manage the active upper GI bleeding. Look at this, that how we will manage. I will just talk step by step about the management of the GI bleeding and how to we approach to the GI bleeding. Continuing to the video, I will talk about just overview that if a patient comes with upper GI bleeding, we should do the rapid assessment and resuscitation if the patient is unstable and he has the severe bleeding. And to decrease the risk of aspiration, we do the intubation to the patients. So there should be not something aspirated into the respiratory system. And the hemodynamic unstable patients should be admitted to the ICU because we need to the close observation that if there is any severe blood loss, we should manage it. And if there is significant upper GI bleeding, the tertiary medical center is required. And further lecture will provide that algorithm approach to the management of acute upper GI bleeding and continuing that how we can manage the acute upper GI bleeding. Just we suspect upper GI bleeding that if the patient comes with the hematitis or in coffee ground like emesis or melena, we say that there is upper GI bleeding. And for the initial clinical assessment, we do check the vital signs, then we go for resuscitation, and we just move to the stabilization of the patient and admit the patient into the ICU, and we should start the proton pump inhibitor like PP infusion soon. And there are two approaches, like if we suspect the variceal hemorrhage, like if the patient is with cirrhosis, and then we suspect that the portal hypertension may cause the variceal hemorrhage, and if there is no risk of the cirrhosis or other uh, things that there is no non-cirrhosis, we go that we do the pre-endoscopy risk assessment by three scores. We have many criteria like that, but we score them according to the many laboratory things, vital signs like this, the Glasgow Black score, the M65 score, and the T score are required to do the risk assessment before we go for endoscopy or further treatment. Well, if we suspect variceal hemorrhage in a patient with portal hypertension or cirrhosis, we go just that we should do the intravenous steroid that may stop the GI bleeding, like they're very helpful for us to stop the gastric or esophageal bleeding, and broad spectrum antibiotics like doxycycline, minocycline, aminoglycosides, or the ampicillin like that, and we use the non-selective beta blockers like propranolol, nadolol, pindolol, labetalol that may be useful to stop the GA bleeding. Further, if we first we have used these the medications in the initial treatment and the initial arrangement and management, but then we do perform urgent esophageal gastroscopy and we do the ligation. Like look at this picture, there is varicose ligation band. Uh, so the venal the venous that is the source of bleeding should be bent like this, and this shows the typical endoscope that there is bending of the uh, submucosal varicose. And then we go, if there is rebleeding, then what should we do? We do the tips, like if the patient with varicose hemorrhage and that didn't the bleeding didn't stop with the ligation bending, then we do the tips, like this is the transjugular intrahepatic orthosystemic shunt procedure, or it is like a surgery. What is this? We just use the shunt between the portal vein and the hepatic vein. So the portal vein pressure should be decreased, that may be helpful in decreasing the vaiceal hemorrhage and may stop the bleeding. This procedure is typically good to stop the bleeding in a patient with the vaiceal hemorrhage. Uh, well, if in the patient we don't suspect any vessel hemorrhage, we do the pre-endoscopy risk assessment like different score scale like Glasgow blood score. We use that like blood urea. If the blood urea is more than 6.5, we can score them. The hemoglobin, if the hemoglobin is less than 12 in men and in women less than 11.2, then we do the blood transfusion. We should see that the systolic blood pressure should not be less than 90. If it is less than 90, then the patient is unstable. And continuing, we will check the pulse rate and then the history and comorbidities like if the patient has syncope and the hepatic diseases or cardiac failure. We just look in the uh, short history of the patient. And the second one is the AIMS 65 score. We see that each variable will have one score. Albumin less than 3 gram per deciliter. INR, sure, if there is more than 1.5, it will have a one score. Systolic blood pressure less than 90. The altered mental status and the age, if it is more than 65 years, it will get one score as well. So if the patient has about two score, we cannot we will not admit the patient in the ICU. If the score is more than two or three, then we should admit the patient in the ICU and will have the close observation of the patient. T-score is also considered while we do the pre-endoscopy risk assessment, but this is not important as well. The first two are important and mostly taken into consideration for the risk assessment. And continuing to the pre-endoscopy risk assessment, if there is more score like more than 12 in the Glasgow score, more than like 10 are in the score of the M65. If there is more score, there are like more than three scores, we do perform urgent esophagogastroduodenoscopy, and we see if there is peptic ulcer bleeding, like in the gastric ulcer or in the duodenal ulcer. We use the epinephrine or some thrombocoagulation or some clips to stop the bleeding. If the bleeding stop, then we see that we didn't see any rebleeding. Then we use the continuing the PPI therapy or the H. pylori should be eradicated in that patients. And if the bleeding reoccurs, then we do second attempt to endoscopy therapy, like let's see what happens again in the peptic ulcer. And then we do the arterography with mobilization, like we do gelatin or something to stop the bleeding. And if there is arteriovenous malformations like the aortoenteric shunt or the malreverse tear or delphi ulcer or lesions, then we just do the endoscopic therapy, some epinephrine, we use the clips or thermocoagulation drugs. And if uh, using this, then we will be unable to stop bleeding. If there is like bleeding is not being stopped, we use the arterography with immobilization, like we use the gelatin or something to stop the bleeding in that case. And if we see with esophagogastroduodenoscopy that there is erosive esophagitis, we will just continue PPI therapy and there will be no further assessment needed. And if we didn't find any source of the bleeding, we just consider that we should do the small bowel enteroscopy, the capsule endoscopy, colonoscopy, or the arterography with immobilization or tagged red blood cell study. These all studies or therapies are considered to find if there may be some other, like in small bowel, we have some ulcerative colitis or these things that are causing the bleeding. Well, you looked at how we can approach the uh, bleeding in the upper GI tract, and we also saw the different therapies and different methods of the to stop the bleeding in the upper GI tract. Well, I have finished the management of the upper GI bleeding. Thank you for your attention and hope to see you in my next videos and lectures.